Hello, and welcome to our live webcast, Orthopedic Aspects of Cerebral Palsy. Thank you for joining us. My name is Andrew, and I will be the operator for the presentation today. Before we get started, I would like to take a moment to acquaint you with a few features of this web event technology. On the right-hand side of your screen, you will see the text chat window. There's a large window which holds all of your sent messages and a smaller text box at the bottom where you type in your questions. To send a question, click in the text box and type your text. When finished, click the send button. All questions that you submit are only seen by today's presenters. Your questions will be addressed at the end of the presentation. At the conclusion of today's program, we ask that you complete a brief post-event evaluation. Please take a moment to complete this survey in order to receive credit for providing feedback and attending today's webinar. We're joined today by our speaker, Dr. Tamir Bloom, Pediatric Orthopedic Surgeon at the Pediatric Orthopedic Center in Springfield, Jersey City, and Cedar, Knolls, New Jersey. At this time, I would like to turn the microphone over to our speaker, Dr. Bloom, for opening remarks.
Hi, good evening, everybody. We're okay with audio?
Yes, definitely.
Okay, oh, great. Hi again. My name is Tamir Bloom. I am a practicing pediatric orthopedic surgeon at the Pediatric Orthopedic Center. And tonight I will be discussing the role of orthopedic surgery in the management of cerebral palsy. I'd like to thank the Tamir Healthcare System as well as Dr. Wittig from the Department of Orthopedic Surgery here for the opportunity to present to you tonight. So just a brief outline of tonight's talk. I'll start off with an introduction to CP. I'll discuss some of the etiologies and pathophysiology of the musculoskeletal problems that we treat and their orthopedic management. And I'll focus the talk today on gait, on hip deformity, and spine deformity. Some of the other issues that come about when discussing CP that I will not discuss because of sake of time in the scope of the talk include the upper extremity, the diagnosis of CP in infants and toddlers, as well as some of the cures developed by the private industry, some of the future preventative strategies, as well as other technologies that are evolving, such as robotics. So let's start off with a definition. What is cerebral palsy? Cerebral palsy is a condition that is defined by a lesion, primarily by a lesion to the immature or developing brain. This lesion is sometimes called static encephalopathy. The lesion is non-progressive and permanent. This lesion results in a motor disability. That is a disorder of movement and posture. It does result in activity limitations. The disability is permanent but not unchanging throughout growth. And many patients with CP will also have other associated disturbances, such as abnormalities in sensation, perception, cognition, communication, and behavior. About the epidemiology, CP is the most common chronic physical disability of childhood. The incidence ranges from 1.6 to 3.6 per 1,000 live births. The prevalence in this country is about 1 million, and about 17 million people worldwide. Some of the common risk factors include preterm births, as well as low birth weight, but the majority of children with CP are full term. There are a host of other risk factors, both environmental and genetic, but preterm births and low birth weight are two of the most prevalent. The 30-year survival rate is 87%, so most infants with CP will survive into adulthood, and this is largely due to the medical advances over the past few decades, as well as the medical care that these preterm infants receive in the neonatal ICU. There are now more adults with CP than children, and discussing the management of adults with CP is a whole other topic. The economic burden in this country is about $1.2 billion per year and about $1 million per person per lifetime. There are multiple etiologies and pathophysiologies for CP. And again, what they all have in common is a primary lesion to the central nervous system. But there are many different phenotypic variations and severities of cerebral palsy, and perhaps a more apt term would be the cerebral palsies rather than cerebral palsy. Some of the etiologic factors I've listed here, and they can be categorized into the time that they occur, either prenatal, which make up the bulk of etiologies, perinatal, or postnatal. The lesion to the central nervous system is defined as that which occurs anytime less than 3 years of age. And what results from these conditions is most commonly some type of ischemic or hypoxic or inflammatory injury to the brain. And this is much more common than some type of developmental abnormality that occurs. If we look at the cross-section of the brain, the areas that are usually affected are around the ventricles or the periventricular area, and this is related to the blood flow to these areas, as well as the proximity to the ventricles. And if you remember back to medical school, there are corticospinal tracts that traverse this region and give rise to the motor homunculus, the lower extremity as shown here, as well as the upper extremity. So if there's an area of infarct or hemorrhage or ischemia, then this will result in damage to these tracts, as well as possibly the basal ganglia, which is also in this proximity. These neurons are extremely sensitive to oxygen deprivation, particularly in preterm infants. So this is the primary lesion. And because there's such a wide variety of phenotypes with CP, we want to try to categorize these patients in a way that is helpful in both management as well as assessing outcomes. And so there have been a number of different classifications that have been developed. I'll discuss three of them, the most common ones that are used. So the first one is based on the movement disorder or motor disorder. The most common type of movement disorder is spasticity, and this is a type of hypertonia where you have velocity-dependent tone. A simple way to check for spasticity is to check a reflex, or like a patellar reflex, and in a child with spasticity, they will have a increase in their reflex. The spasticity results from damage to pyramidal tracts in the central nervous system. The second most type of movement disorder is dyskinetic movement disorder. These come in two types, either dystonia or chorioathetosis. Dystonia results from co-contraction of agonist and antagonist muscles. These are involuntary movements and arise from damage to the basal ganglia and the thalamus, or what we call the extrapyramidal tracts. And chorioathetosis is the writhing movements of the extremities, again, involuntary, that is also related to extrapyramidal tract injury. Ataxia comprises about 5% of patients with CP, and ataxia is the Y-based gait that you see when you've had too many drinks after leaving the bar. And an ataxic gait is one where each subsequent step is different from the one previous to it. Very unsteady gait. Hypotonia 1%, and then mixed tone is about 1.5%. The next classification system is based on the different parts of the body that are involved. And this is the geographic or topographic classification. And these terms you may be familiar with, including monoplegia, hemiplegia, diplegia, triplegia, and quadriplegia. This classification has been around for 100 years, and it's pretty straightforward to describe. But clinically, sometimes I've had patients where I'm still not quite sure whether they're truly hemiplegic or triplegic. And studies have shown that this classification has quite poor inter and intra-observer reliability. And perhaps the most important classification that has been developed over the past 20 years, and one of the things that has really changed how we think about and treat CP is the gross motor functional classification system. I'll talk about this quite a bit throughout the talk. The GMFCS is based on functional ability and limitations and the need for assistive devices. So here's the GMFCS classification. There are 5 levels. This classification was developed roughly 20 years ago in Canada, and researchers at that time looked at a large cohort of patients with CP and managed and monitored their motor function throughout development. And what they found is that their motor level stratified into 5 different levels. These levels are consistent throughout development. They are stable, and they're valid and been demonstrated to be reliable. The classification has different age ranges going from 2 years of age to 18. And here's a description and illustration of the age range between 6 and 12. And these researchers were pretty bright because they accompanied their description with illustrations so that simple-minded orthopedic surgeons like myself could follow them pretty easily. So let's just go through these. The level 1s, these are the kids that are able to run and climb, but have mild impairments in speed, balance, and coordination. As one of my mentors described them, these are the kids that are chosen last for the baseball team. The level 2s do have difficulty on uneven terrain, and they have minimal ability to perform gross motor skills such as running and jumping. And occasionally they may be seen wearing orthoses. The level 3s use some type of handheld mobility device in indoor settings and wheeled mobility outdoors for long distances. The level 4s require some kind of powered mobility in most settings, although, they may have some limited ability to ambulate with a supported walker. And the level 5s are entirely dependent on wheeled mobility and require 24/7 care. If we look at motor function using different assessment tools and the GMFCS levels, and we plot them out versus time, what we notice is that the GMFCS level peaks at about 6 to 7 years of age, and that the level 3s and higher, most of them will decompensate within their GMFCS level as they go through their second decade of life and into adulthood. The other interesting thing to note about this chart is that GMFCS levels increase in the first few years of life, and so any type of intervention that we do here, whether operative or non-operative, will likely have a positive effect because the natural history is of improvement of the gross motor function. So the GMFCS really helps to change our orientation from thinking about disease and disability and focuses on what on function and participation in activities in our society. And this is a big change compared to a few decades ago. And the GMFCS correlates highly with morbidity and mortality, as well as other orthopedic issues that we are concerned about, such as hip displacement, spine deformity, contractures of the upper lower extremities, as well as bony deformities, as we'll talk about. It helps guides and helps us standardize surgical decision-making and is a essential tool in communication both within clinicians and researchers. It allows us to compare different patients and their outcomes in response to treatment, both within a certain GMFCS level and between GMFCS levels. So let's switch gears and go back to the pathophysiology. The musculoskeletal problems that arise in CP are largely due in part to the loss of the inhibitory signals that come down from the brain or the central nervous system and inhibit the stretch reflex arc. These reflexes are constantly firing, but are held in check by the inhibitory signals that modulate them. These signals rely on the neurotransmitter GABA, or gamma aminobutyric acid. And so without these inhibitory signals, these reflexes are overactive and they're poorly modulated. And this lack of inhibitory signal results in what we call the upper motor neuron syndrome. This syndrome has both positive and negative features. Most of our modalities in orthopedics are focused on the positive features because we can address these, whereas the negative features are more difficult to address. So what are the positive features? Spasticity, hyperreflexia, clonus, and co-contraction. And to the developing skeleton, these cause contractures and posturing. They can twist the spine and cause scoliosis. They can literally, because of the strength of the muscles, pull the hips out of the sockets, contractures of the lower extremities, as well as they can deform or twist the bones of the lower extremities. The negative symptoms, which are very important to consider, are weakness, impaired selective motor control, poor coordination, and sensory deficits. And these are all going to impact our non-operative and operative treatment options of these problems. It is a large part with the help of therapists that we're able to address some of these issues. So what is the role of the pediatric orthopedic surgeon? We do have a role in helping the pediatricians and neurologists in terms of making the diagnosis early on in life, which can be challenging, particularly in less than 2 years of age. What I'll talk about mostly is the orthopedic problems. So our role is to monitor and treat these musculoskeletal problems, particularly those that affect gait function and that develop over time. What we commonly see is that a child, say with spastic diplegia, will have hypertonia and spastic muscles in their lower extremities. And as the child gets older, these will become contractures. The difference between spasticity and contractures is that when the child is asleep under anesthesia, all the spasticity resolves. So any limited motion of the joint that you see will be as a result of either a contracture or possible bony deformities. As these kids get older, they start to develop bony deformities because of the abnormal forces on their skeleton, primarily the lower extremities, and this can result in hip displacement, as we'll see, as well as a decompensation of gait in the second decade of life. So within the scope of these problems, some of the issues that we deal with include setting appropriate goals for our interventions, deciding which surgical interventions we should do and when we should do them, also the surgical dose. But this I mean that there are, for example, half a dozen different ways to lengthen the gastrosoleus muscle. Some are more powerful than others, and they all have different pros and cons. So deciding how much to lengthen is an important decision that we need to do, as well as coordinating care. Many of these patients will have other comorbidities or clinical manifestations. And although I primarily focus as an orthopedist on the movement and posture disorder, some of these clinical problems can have a greater impact on the quality of life and the health of the patient than addressing this issue. I am just one of a team of individuals that is many times required to take care of, optimally take care of patients with cerebral palsy. So when taking care of patients, we want to have clear goals and priorities, and we want to make sure that those are aligned with that of our patients. Well, if we ask individuals what their priorities are in life, we see that walking, which is something that we're most focused on as orthopedists, doesn't make the top three. There are other priorities that are much more important, including communication, independence, ADLs, and having a job. These tend to be much more important than either functional mobility or walking ability. And I would argue that two of the most important jobs in the world, that of being a parent or being the president of this country, can be done quite successfully without the ability to walk independently. One of the things that we also want to understand or recognize is the impact of the disability on the individual. This is the International Functional Classification Model of Disability, and when we apply it to CP, we as orthopedists again focus on the body function and structural impairment, and our goal is to improve this so that we can improve activities and thereby improve participation into society. So participation is what the patient wants to do. And these are affected by both environmental and personal factors. So how about management? A great deal of the management of patients with CP revolves around managing their spasticity, as this is the most common motor disorder. There are many different modalities that we use that can either act generally or they can act focally. Another way we can think about these treatment options are those that are reversible, such as various medications and orthoses and therapy. Botox or intrathecal baclofen, and those that are permanent, including selective dorsal rhizotomy that is performed by my neurosurgery colleagues, and we are over here in orthopedic surgery. The important thing to recognize is that all these modalities should be integrated for the optimal care of a patient with CP, rather than using them hierarchically. So let's focus on the orthopedic treatment of GMFCS levels 1 through 3. These are the ambulatory patients with CP that comprise about 65% of all patients with CP. So here's a child with spastic diplegia, and so what are our goals for this patient? Well, we want to optimize their gait. And again, we hope that by optimizing their gait, we can preserve or improve their physical function, their activities and participation, and their quality of life. We also want to relieve or prevent pain and fatigue, and help protect and prevent against future deformities, either to the upper or lower extremities and to the hips. So if we just focus on one deformity, if we just focus on the ankles, we can see that this child is standing on their toes, or what we call an equinus deformity. And if we take a history of and talk to the patient and their caregivers, as well as perform a physical examination, we can find that some of the problems that they may encounter include ankle sprains, as walking on your toes can decrease the stability of the ankle. Walking on your metatarsal head can result in callosities that can be painful. This position of the foot can make shoe wear difficult. And what we are really interested in is what is the effect of walking in this position? How does it affect gait? And so I can have this child walk in my office, and I can take pictures on my phone, or I can take a video and make some observations. And this would give me a really good descriptive assessment of their gait. And this is kind of similar to what Leonardo da Vinci did with watching currents of water in a river back in the 1500s, and he was able to glean some very important insights. But now we have much more powerful technology. For example, we have laboratories for performing fluid flow analysis, and by studying these models, we can understand how water flows in different settings, and this gives us a mechanistic understanding of water flow. Well, we can do the same thing for gait. We have the technology to be able to understand not just what gait is, but how gait works, and then we can develop insights on when gait becomes pathologic. And so the technology of 3D motion capture instrumented gait analysis has been around for quite a while. This is the same technology that's used to make all those wonderful Pixar movies. And essentially what this involves is hooking up a child with some electrodes and reflective markers, and have them walk on a forced platform in the lab, and there are a number of gait labs that are readily available within our region, and the data that we can collect is quite astounding. We're able to get information on joint forces or kinetics. These are ground reaction forces. These are the forces that counter the forces of gravity with walking. We're able to measure moments, which are forces that act as a distance, and we're able to measure joint motion or kinematics. This is joint position, angle, velocity, acceleration of body segments and joints, as well as using electromyography to get muscle activity. And so reading these graphs and understanding pathologic deviations is, again, beyond the scope of this talk, but I think it's important to understand just some of the basic principles of gait, and then you can understand how some of our orthopedic interventions work. So here's the gait cycle. There's a few pieces of equipment that we need for normal gait. We need a control system, which is the brain, which is obviously impaired in folks with CP. We need an energy source, and this is the biochemistry of our muscles to generate energy. The levers, these are the bones that provide movement, and the forces that move the levers are the muscles. So the muscles are affected in folks with CP, and some of the levers may be affected as well, as we'll see. So for normal gait, we need to have the right equipment as well as certain prerequisites. We all walk in a certain way that is fairly consistent because it follows the following prerequisites, and these prerequisites, you can imagine, will be affected in someone that walks in equinus, such as stability and stance, as I mentioned, proper clearance of the foot in swing. So we need to be able to clear the foot so that we don't trip on it when we take a step. We need to properly preposition the foot with heel strike on initial contact. We need to take an adequate step length and use energy conservation so that we walk in the most energy efficient way. And so all these could potentially be impaired in someone within the GMFCS 1, 2, and 3 level. So the beauty of gait analysis is it allows us to obtain a much more complete picture of gait abnormalities. And what are some of these abnormalities that we may see in a child like this? They may include abnormal muscle activity, more energy demand, reduced velocity, walking distance, and increased strain on joints, ligaments, muscles, as well as bony deformities. We can use gait analysis to monitor the deterioration of gait over time, potentially, and we can classify as well as understand different gait patterns in our patients. We can use this understanding to improve gait efficiency and comfort with our interventions. So as of today, and this was not the case even upwards of 5 to 10 years ago, today the standard of care for the orthopedic treatment in ambulatory CP is gait analysis. I think it's important to recognize the surgical interventions that we do. The way they work is a large part to address what we call lever arm disease. And to understand lever arm disease, you need to basically understand two concepts. One is that our limbs are essentially levers or simple machines. And levers are basically the bones that a force is applied to. That is, a muscle applies a force at a certain distance, and this causes movement over the fulcrum or the joint. And so that is the first part. And the second part is that the growing skeleton in someone that has cerebral palsy can start to deform because the muscles apply forces to these growing bones, and the bones respond. And so with abnormal muscle forces, you can have bones that either twist pathologically, particularly the lower extremities because of the effect of gravity, and you can have displacement or malalignment at the three main joints of the lower extremity, the hip, knee, and ankle, as well as multiple deformities or displacements of the foot. And so, so what happens to synthesize these two concepts? If you have abnormal anatomy and abnormal forces, then this results in abnormal moments, abnormal location of the load. So if you have forces that are applied at a shorter distance, this will decrease the moment. If you have forces that are applied at an angle, this will decrease the moment as well. And so this will increase the energy expenditure of walking if any of these abnormalities exist. And so by combining or synthesizing multiple pieces of information, we are able to come up with a list of problems and then possible solutions. So the information that we use is from the history, the clinical history, the physical examination, x-rays, the GMFCS level, Sometimes we use other functional classification or assessment tools, and the gait analysis. And by combining all this information, we can come up with a list of problems or lever arm diseases, and we can then figure out what is the best possible intervention. So in terms of the orthopedic surgeries that we perform, they can be either soft tissue or skeletal procedures. And I know this diagram is a little complicated, but there are multiple different types of procedures that we use to address lever arm disease, as well as contractures or malalignment that is found either at the hip, knee, or the ankle. And so, for example, we can, for equinus, we can lengthen the tendon. If there's an imbalance or displacement of the limb, we can weaken tendons and transfer tendons. In terms of our soft tissue procedures, we can also lengthen or weaken muscle. And in terms of our bony interventions, we can derotate limbs if there's pathologic torsion, and we can fuse joints if they're severely malaligned. What are some of the principles of orthopedic surgery? The surgeries that we perform are usually done in one surgical setting. We want to correct all the problems that we identify in terms of the gait and pathology and deformities at one time. And this is known as single event multi-level surgery, or SEMLS. If it involves both extremities, many times we'll do both extremities and try to do as many surgeries as the patient can handle, in one setting. This allows for one large surgical setting rather than multiple procedures that are done in successive years as children develop successive deformities, which is what was known as birthday syndrome in the past. After these procedures, and sometimes we're doing anywhere from 10 to 20 procedures in one day, and sometimes in conjunction with Botox. There's a brief period of immobilization followed by intensive physical therapy. We consider performing our surgical intervention when gait begins to deteriorate or compromises the individual levels of function, and this usually is no earlier than 6 years of age. We have gone away from thinking of surgery as a last resort or a failure of Botox or casting or other interventions. We want to, however, integrate non-operative spasticity management options along with the surgeries, and we want to continue to assess the changes with treatment and with continued growth of the child. And we also want to set realistic goals for patients and their caregivers. If we plot the age of the child as well as the frequency of intervention, our SEMLS procedures are performed between about 7 to 12 years of age. This is the sweet spot over here. And again, we do use other modalities during this time period as well. The only time that we intervene surgically earlier in these patients is to address hip instability. Earlier on, the first few years of life, therapy, orthoses, Botox comprise the majority of treatments that we use. So what are the results of our SEMLS interventions? What can we expect as an outcome, and what can we tell our patients and their parents to expect? Well, if you look at the natural history, once a child reaches the end of their first decade, particularly the 3, 4s, and 5s, the natural history is a decompensation. The effect of SEMLS is to maintain their current level of GMFCS or helps to optimize the efficiency of their GMFCS level. It is rare that we're able to bump someone up to a lower GMFCS level, that is from a level 3 to a level 2. That really is not realistic, and it does rarely happen. But SEMLS has been shown to prevent this deterioration in function. So let's move on from gait to two other conditions that we treat, and one is hip displacement. Neuromuscular hip displacement in CP is quite different from DDH, or developmental dysplasia of the hip. In CP, the hip is normal at birth, but can start to sublux and dislocate throughout the first decade of life. It can start as early as 2 years, but usually by 7 to 8 years of age. The progression may be rapid, perhaps within 1 year from being subluxed to completely dislocated, or it may be quite slow. There are unfortunately few signs or symptoms until the hip is dislocated, as shown here. Once the hip starts to sublux and dislocate, it can start to degenerate and become quite painful, particularly in the adult population. If the hip is not monitored, the incidence of hip displacement in CP is about 1/3 of children, and the incidence increases almost directly with the GMFCS level. And this is another amazing thing about the GMFCS level, is that it's highly correlative of the incidence of hip displacement, with most hips, with the most highest, greatest percentage of hip displacement in the level 4s and 5s. So what are the problems with the hip that is displaced or subluxed? In ambulatory children, it can affect standing and walking ability. It can cause pain due to contractures or osteoarthrosis. It can interfere with perineal care, with dressing and diapering. And so this child, I believe, is a GMFCS 5. He has this windswept deformity where the legs are angulated towards one side, and this most likely means that this right hip is out, and trying to abduct this hip to dress or to provide perineal care can be very difficult once the hip is dislocated, because a dislocated hip can cause severe limitation of motion of the hip. And again, as I mentioned, it can be quite painful. It can affect sitting balance and comfort. These level 4s and 5s are usually spend most of their time in a wheelchair, and so having sitting imbalance because of one hip being out, which can cause pelvic obliquity, can be quite problematic. This can also cause pressure ulcers from the obliquity. So what are our goals of management for hip displacement? We want to be proactive and keep the hip flexible and located. We don't want to be doing salvage surgeries to take a hip that's out of the socket and put it back in, particularly once it's been out for a while, because the hip starts to deform and become osteoarthritic, as I showed you in that clinical picture. In order to prevent this from happening, we want to monitor it throughout growth. And now we have really excellent surveillance guidelines that, again, rely on the GMFCS as well as age to tell us, when we should be monitoring these children, both by clinical examination as well by X-rays. And if we start to see that the hips are coming out of the socket, then we perform surgery to keep them back in. Unfortunately, preventative strategies such as therapy, abduction or orthoses and Botox, they may delay surgery, but they rarely prevent progressive hip dislocation in this population. Again, we want to be doing preventive and reconstructive surgeries rather than salvage surgeries, which have a higher rate of complication and a poorer outcomes than preventative or reconstructive surgeries. Here's an example of a child with bilateral hip dislocations who underwent bilateral femoral osteotomies to realign, reposition their hips, as well as acetabular-plasties to reduce the volume of the acetabulum to help constrain the hip, because many of these children will have increased volumes of their acetabulum. How about spine deformity? Neuromuscular scoliosis is quite common in the level 4s and 5s. The lower levels, it is quite rare. So these are the patients that we have to watch their spine very carefully. The scoliosis and other spine deformities that these children develop is quite different from adolescent idiopathic scoliosis. AIS usually arises later. The curves in CP tend to be stiffer, tend to be bigger, and less responsive to bracing. These curves can make sitting difficult. They can cause pressure ulcers, as shown here, chest deformity. They can cause pulmonary deficiency once they get quite large, and they can shorten someone's lifespan. And so our management is both non-operative and operative. Non-operative management includes observation for smaller curves, sitting support, occasional orthoses, but unfortunately, while these may delay surgery, they rarely prevent progression. Our indications for surgery is roughly 50 degrees Cobb angle, although that's is variable depending on the location of the curve, as well as deterioration of functional sitting. Surgery usually entails a posterior fusion, instrumented fusion from the thoracic spine to the pelvis. These patients are usually GMFCS 4s and 5s, so they have multiple comorbidities, and this is part contributory to the high surgical complication rate. However, there are tremendous benefits in this population, including improving sitting balance, comfort, and endurance, appearance, ease of care, overall quality of life, as well as patient and caregiver satisfaction. And here's an example of a child with a neuromuscular scoliosis who underwent a posterior spinal fusion from the thoracic spine down to the pelvis. And so we can tailor our treatment based on the GMFCS level, and these are just guidelines of some of the interventions that we need to do. It should be kept in mind that every child with CP is unique and requires their treatment to be individualized. So the level 1s may need Botox, rarely orthopedic surgery, lots of therapy, occasionally surgery for the upper extremity and hemiplegia, and little to no hip disease or scoliosis. The level 2s, Botox as well as orthoses, occasional selective dorsal rhizotomies, which is performed by my neurosurgery colleagues, occasionally SEMLs, and we screen the hips and perform preventative surgery. The level 3s, Botox, phenol, sometimes intrathecal baclofen. Baclofen is quite helpful in managing dystonia. In these patients, we screen the hips and perform hip surgery to prevent hip displacement, as well as seminal surgery. And the level 4s and 5s, I'll finish off by talking about this group of patients. These usually have mild to severe spastic quadriplegia, very high incidence of hip displacement and scoliosis, as we mentioned, and a significant amount of contractures to both upper and lower extremities that can affect the ability to sit comfortably in a wheelchair or in a supported mobility device. They have a high rate of comorbidities, which we have to consider both preoperatively, perioperatively, and postoperatively. Our goals in these patients are to prevent or relieve pain and discomfort, to facilitate caregiving, to preserve or improve the patient and caregiver quality of life. And we always want to have in mind their entire health status as well as the entire child, but the other comorbidities as well as their caregivers. We screen the spine and hips, intrathecal baclofen that is performed by, again, my neurosurgery colleagues, orthopedic surgery to improve standing and sitting comfort and endurance, hip surgery, spinal fusion, and lower extremity and upper extremity reconstruction and fusion. So in conclusion, we want to set goals to facilitate integration into society and maximize function later on in life. We want to have the same perspective as the entire healthcare team in terms of what interventions would be most beneficial, orthopedic or otherwise. We want to have a shared decision making with patients and their families. You want to keep thinking dynamically and reevaluate patients as they develop throughout growth. The GMFCS, I hope I was able to convince you of its importance in both natural history, outcome assessment, and guiding our surgical decision making. We now have this standard tool to help us with assessing gait pathology, and this has really revolutionized our care of gait in patients with CP. Our surgeries now are tailored to be aggressive and proactive rather than reactive as they used to be in the past. And so I'll finish off there, but I'd like to acknowledge some of the thought leaders over the last 3 decades in the field of care for CP in the orthopedic community. These are some of the most influential thought leaders and some of my mentors and wonderful people to spend time with. Jim Gage from Minnesota, Kerr Graham from Melbourne, Australia, and Dr. Chambers from San Diego. These folks have truly pushed us to the next frontier in terms of orthopedic care for patients with CP. So I'll thank you for your time, and I think we'll take any questions that come up.
Just as a reminder, text chat is located on the lower right-hand side of your screen. To submit a question, type your question in the small text box at the bottom, and when finished, click the send button. Please note that due to time constraints, our panel may not be able to respond to all questions submitted.
So there was a question about the role of obturator neurectomy. This is a procedure that had been done in the past. I have yet to do this procedure. The concern with doing an obturator neurectomy is that you may completely knock out the abductor muscle function in someone who has a limited hip abduction. But if you knock out the abductors, then you can get unopposed abduction, which can lead to the opposite deformity, which could potentially be an even greater problem. This is the same problem sometimes with using alcohol, which can demyelinate the nerve. And so we typically use Botox to address abductor spasticity. I had another question about CP and autism, and is there a link? I'm not a neurologist, so I'll have to punt that question to the neurologist, but there are certainly autistic features in many patients with CP. I also have seen kids diagnosed with autism when, in fact, they have CP type symptoms. That is primarily a motor movement disorder. And so I certainly think that there's an intersection between the two conditions. But again, I'll have to defer to the neurologist about a more definitive answer. So there was a question about a child that has numbness in one digit and bilateral ankle contractures and whether they have cerebral palsy. Well, ankle contractures can be the result can be, or what we typically see is toe walkers. So contractures are something that is diagnosed clinically, but toe walking is something that the parents come in complaining or noticing in their child. So toe walking can have multiple etiologies. One of them is CP, but there are other etiologies. Probably the two most common are idiopathic toe walking, as well as Duchenne's muscular dystrophy. We can use our clinical exam, assessing reflex, obtaining good birth developmental history to help us kind of tease those things out. Whether numbness in a finger is associated, it's probably unrelated. The primary problems in CP are related to motor movement disorders, although, again, the negative features, including balance control and weakness, are also manifestations rather than numbness. So I had a question about why spasticity is more in CP. I believe what the audience member is asking is why is spasticity the most common motor movement disorder in CP, and I think it has to do with the pathology. So again, 90% of patients with CP will have healthy brain tissue that then gets exposed to some type of ischemic or hypoxic or inflammatory event. And again, the regions around the ventricles, which have the corticospinal tracts that hook up to the motor homunculus, are the ones that are primarily involved. So there are certain other areas of the brain that can be affected. Again, the basal ganglia, thalamus, cerebellum, but these are the ones that are involved in most patients. I hope that answers the question. So what is CEMALS? CEMALS is a single event multi-level surgery. So this is performing one surgical intervention, typically between 7 to 12 years of age, where we address all the pathology that needs to be addressed surgically in one setting, or as much as the patient can handle based that would be healthy for them, rather than performing one procedure and then a couple months or a year later performing another procedure. We want to prevent what's called the birthday syndrome, which is as the child continues to grow, they continue to develop contractures and bony deformities, and intervene kind of in a reactionary approach, because this basically places the child in a position where they spent most of their childhood either in the hospital recovering from surgery or in physical therapy. So we want to try to do as much as possible in one surgical setting. So I had a question about treatment options in adulthood. I do not see adults, but one of former mentors, Dr. Chambers, has perhaps probably the largest adult CP clinic in the country, probably even the world. He's seen thousands of adults over his past 30 years, and the great question to find out from him, but a lot of the problems that he sees can be mitigated with intervention, both non-operative and operative, in childhood. So again, addressing issues surgically, particularly with the hips and the lower extremities, can prevent a lot of the problems that we see in adulthood. But this is a great question, and I think that it is a field that it needs more research, certainly more research, as well as clinicians that specialize, because this population continues to grow. So I had a question about, is it possible to do surgery at 15 years old? Absolutely, as long as the child is healthy, and the risks of anesthesia and the surgical intervention are reasonable. It depends on what the problem is, but certainly we do big surgeries, hip reconstructions, as well as spinal fusions in 15 years old. But these are patients that if they have a higher GMFCS level, may have greater comorbidities, and so shared decision making is required in order to recommend the best treatment option. So, the agent itself doesn't seem to be a contraindication for surgeries. We do know that in terms of the CEMLS procedures, again, the sweet spot for doing these surgeries is between 7 to 12 or 13 years of age. I've certainly operated on older kids. It seems that their outcome in terms of maintaining or improving their GMFCS level has not been demonstrated to be as predictable as those in the younger age group. All right, so I think we'll leave it at that. And again, thank you everybody for your questions, and thank you for your time. Have a wonderful evening, and stay safe.
On behalf of the Atlantic Health System, Morristown Pediatric Orthopedics, I would like to thank you for your participation in today's event. You will now be redirected to the post-event survey requesting your feedback. Please take a moment to complete the survey in order to receive credit for providing feedback and attending today's webinar. This concludes today's program. Thank you and have a great day.